All right, so we're going to go ahead and begin this webinar. I thank everybody for their interest and participating in this. This is brought to you from the AUR's RRA and RASER. This is a series of webinars on online statistical training for radiology researchers. I'm Andy Rosenkrantz from the NYU Langone Medical Center, and this initiative is supported by a venture fund grant from the AUR R&E Foundation. And this first talk in the series is entitled Individual Comparisons, Parametric and Non-Parametric, Part 1 of 2. Just some initial background. So as I said, this is a joint effort from the RASER and RRA. Our aim is to support the design and conduct of high-quality radiology research. This will be a series of webinars and biostatistical training, and these will be recorded and then made publicly available on the AUR website. We are having a Twitter feed available for this. The hashtag is RadioStats, so you're very much encouraged to follow along with that. The audience can interact during the session, and then afterwards I'll field any questions that anyone may have using Twitter. Before getting started, just some additional caveats. The aim is to present broad concepts in a very straightforward fashion. So this is very much at an introductory level. The approach will involve simplifications, but hopefully it will be helpful for your understanding. In addition, I'm not a biostatistician. I do have experience, though, in applying biostatistics for radiology research, and certainly the audience is encouraged to consult further references and to collaborate with a trained biostatistician during your study design and analysis. And one additional caveat not on the slide, I am a body imager, so I'm going to try to have this be rich with examples, and there will be a little bit of body focus with some of those. So the specific purpose of this talk is individual comparisons. So this will involve selecting the appropriate statistical test, generating p-values, and I'm going to try to maintain a focus on tests or statistics that you can do yourself. And this presentation, I had this initially prepared as a full 1-hour session, but we were asked to divide this into 2 smaller presentations. So part 2 will be next week on Tuesday, actually it's on Tuesday, May 10th at 6 p.m. Eastern. So just before moving again further, just some general caution with statistics. The statistics is only one facet of the quality and rigor of a given research study. So having robust statistics is not going to ensure a high quality study. I think more important is whether the study was well designed and conducted in the first place. We can have even the most elegant statistical analysis, and that will not compensate for or correct for a flawed study design or poor data collection. We also need to have caution with p-values. There's a lot of attention on the p-values. Are they significant or not? These reflect the statistical confidence in the presence of a difference between groups, irrespective of the size of that difference. So it's impacted by the observed difference as well as by the sample size. The larger the sample size, the more confident we can be that the given difference is significant. So a p-value of less than 0.01 does not indicate a larger difference than a p-value of 0.05. It just indicates we have a greater confidence that a difference actually exists, whatever it is. We can keep the difference between the groups the same, and by just increasing the sample size, the p-values can become smaller. So if we have a very large sample size, even a small difference that perhaps isn't really much clinical meaning will be statistically significant. And if we have a very small sample size, an important difference may not be significant. In terms of reporting p-values, it's discouraged to simply report the p-value itself. Again, this is just the confidence. It's not the actual result. So for instance, perhaps I'm reviewing a manuscript and I see this phrase, T2 hyperintensity and tumor grade were significantly associated, p-value of 0.049. But this does not indicate the size, or in this case, even the direction of the difference. We don't know which group, in terms of low or high grade, was more likely to have T2 hyperintensity. We could see that T2 hyperintensity is significantly more common in high-grade tumors. This now gives us the direction, but still not the actual size of the difference. So again, the p-value is the confidence, but it doesn't actually, it's not the actual data. What we would like to see is that T2 hyperintensity was significantly more common in the high grade at 80% than in the low grade at 60% tumors with the associated p-value. An additional point of caution, so a true significant difference still does not imply high diagnostic performance. There may be substantial overlap between our groups despite a p-value of less than 0.05. So again, we can't rely too much on these, and we need additional tests when interpreting the data. For instance, visual assessment of just the actual data distribution in the two groups, often done with a box and whisker plot, as well as ROC analysis. Here I just have some sample data from just a separate study, and here we have some metric, and we're comparing it between two readers. We see here there's actually just visually that there's substantial overlap between the two data sets, but the mean values were actually a good bit different, and for this particular project it came out statistically significant, yet that doesn't really indicate that the degree of overlap we see from the actual plotting of the data. And at ROC analysis, the diagnostic performance, the area of the curves for the two groups were similar. Okay, so now actually to talk a little bit more about p-values. So you may have heard of one-sided versus two-sided p-values. The two-sided p-value will always be twice the one-sided p-value. So if the one-sided p-value is 0.01, then the two-sided p-value is 0.02. In biomedical research, we generally will choose to use two-sided p-values. This is basically the default. This is what's expected. If choosing to use the one-sided p-value, you're going to need to make a good argument in your methods as to why you're doing that. In terms of what this indicates, the two-sided p-value, this indicates that there's at least a possibility that either of the two groups being compared could have the larger value. A one-sided p-value implies that we are confident before even collecting the data that only one of the groups being compared can achieve a better result, and we would attribute an observed outcome in the opposite direction as artifactual, and that will rarely be the case in medicine and biology. So we take an example. We're comparing the accuracy of T2-weighted imaging and diffusion for tumor detection in whatever organ we're studying. Now, we expect diffusion will be more accurate, but it's still possible that T2 may actually do better, so we should use a two-sided p-value. If we would be willing to reject as erroneous even the most extreme alternate outcome than expected, say T2 performed better than diffusion for every patient in the cohort, and we would say it's just not possible to reject it, then we may be justified in using a one-sided p-value. All right, so with that in mind, so now I want to move further towards being able to pick what the correct test is to apply to our data. To select the test, we actually have to first understand the nature or type of data that we have for our given study design. And once we can actually characterize the data, then it becomes much simpler, as we'll see, to pick the test. And there's really three questions I list here, and we'll go through each of these, that we should ask ourselves about the data that we're using. Is it parametric or non-parametric, paired or unpaired data, and are we using independent or clustered observations? And once we select that, it kind of leads directly into which test to use. So first, parametric versus non-parametric. Parametric tests, these make assumptions about the distribution of the data. These are more powerful tests and will tend to give stronger p-values for a similar sample size and size of the difference. But at the same time, if we use a parametric test when these test assumptions are violated, then we'll obtain misleading results. On the other hand, the non-parametric tests, these do not make assumptions about the data distribution. These are therefore more robust. We're generally safe to use these tests when we're unsure, but these may weaken our statistical power if we could have used a parametric test. So to talk more about what this means, so the parametric data, this generally can be fit or can kind of be conceptualized with a normal distribution. It's data that if we were to measure this data in a very large sample, we'd expect it would generally follow this type of pattern. So we can kind of get at that by thinking which of these categories does our data fall into, and I'll go through each of these: categorical or nominal, ordinal, or continuous or interval. These last two, continuous and interval, there is a difference between these, but for purposes of this talk, we'll just kind of treat these as together. And each of in these groups, we can kind of map out to being parametric or non-parametric, which I'll cover. So first, the categorical and nominal data. This is data that falls into discrete, non-overlapping categories, but there's no inherent ranking or ordering of the category. So patients' gender, ethnicity, their eye or hair color, their blood type. Again, we can assign our patients to these different groups, but these aren't really a measurement or have any ordering to them. Similarly, for the realm of imaging, whether a lesion is detected or undetected, whether certain imaging features such as hemorrhage, necrosis, T2 upper intensity is present or absent in our lesions. We can form these different groups or buckets and place the patients or lesions into these, but it's not really an ordinal scale or direct measurement. Ordinal data, this is data that can be ordered or ranked, but still not truly measurable. So there's an arbitrary or inconsistent variation between points on a scale. So this would be any type of subjective quality scale, say image quality scores from 1 through 5, just a reader's subjective assessment, an APGAR score, 1 through 5 star ratings of movies and restaurants. Or in our universe, this could be, say, patient satisfaction scores. So there's a ranking here, but it's not really directly measured. So let's take an example of imaging. Say we're looking at the image quality of some image set, the ADC map. These tend to be noisy, and we're acquiring these with different sequences, and reviewers are looking at them and giving image quality from 1 through 5. A score of 4 is better than a score of 3, which is better than a score of 2. But a score of 4 may be much better than a score of 3, and a score of 3 may be slightly better than a score of 2. And the ADC map with a score of 4 isn't necessarily exactly twice as good as a map with a score of 2. So again, there's a ranking here, but there's not really a continuous scale. There's no true definition of a score of 0, and we agree that a score of 1 will have the worst image quality, but it will vary among observers exactly what that is. And then the third group, we talked about continuous data. This is truly measured. The values have clear meaning. The difference between the points also has consistent meaning. So patient's age, lesion's length, height, or weight, a Hounsfield density, a quantitative ADC measurement, an enhancement ratio. So if you think of age, somebody who's 60 is exactly twice the age as somebody who's 30. The difference in age between individuals who are 30 and 40 years is the same as the difference between those who are 40 and 50. So here the numbers don't just indicate relative rankings, but are true measurements. So back to the issue of parametric versus non-parametric data. So for those first two data types, the categorical data and ordinal data, a non-parametric test is typically warranted. This type of data generally we can't really fit to a normal distribution. For the continuous data, a parametric test is typically warranted. And we can use the parametric test, which generally will give greater power for that type of data. There are still some circumstances where we would use the non-parametric test even for continuous data in which the normal distribution would be less likely, and it's important to be aware of these and to consider these for your studies. Say if you have very small sample sizes, under 20 patients in a given group, if you have extreme outliers or heavily skewed data, even if its data is continuous, say lesion length, we often would use a non-parametric test in those circumstances. So often you may plot your data and visually look at how it falls. there are some statistical tests that software packages can do to actually test your data and see if it has a normal distribution. I named some of these here, and then there are packages available that can do these. And if we run this on our data and we get a p-value greater than 0.05, we often will accept normality of the data and feel the parametric test is warranted. When it's less than 0.05, we'll reject normality and use a non-parametric test. Another question to ask ourselves about our data, and this is a different question from the parametric unparametric question. This is the data paired or unpaired? And for whether it's parametric or non-parametric, the data may be either of these. So unpaired data, the subjects in the two groups being compared represent two distinct cohorts. We cannot link up individual cases in the two groups. So this would be ADC values of the liver in male versus female volunteers. ADC values in HCC that do and do not respond to TACE. This might be the sensitivity for right lobe versus left lobe tumors. Again, these are two different groups. The lesions in patients aren't matching up. In paired data, each individual contributes a data point to each of the two groups being compared. The ADC value of liver lesions before and after embolization. The ADC value of liver lesions at 1.5 and 3T in the same group of patients imaged at both. The size of lung nodules measured on CT and MRI, again, the same nodules imaged both ways. The image quality score in the same patient on CT and MRI. The length of the right and left kidney in a given patient. Again, here we can go down our list of lesions one by one and match them up between the two groups. In terms of why this is relevant, the paired data tends to give stronger p-values. It's more controlled. This eliminates underlying differences between the two groups. With unpaired data, there's likely to be differences that we just can't really predict or account for, and this will weaken the p-values somewhat. And then the third item, so the third question to ask ourselves, beyond the parametric and non-parametric and paired versus unpaired, is the data independent or clustered? If we have independent data, then without exception, each patient is contributing only a single data point to each group being compared. If we have multiple observations of the same lesion over time, of different lesions in the same patient, or of different lesions in different regions of the same patient, say there's different hepatic segments or different colonic segments, that all violates independence. To achieve independence, we need to apply a rule to select only a single lesion per patient, whether we take the largest lesion, the most suspicious lesion, the lesion with the most extreme, some type of quantitative measurement, or even selecting some lesion at random in each patient. So if we have cluster data, now we have at least one instance of one patient contributing more than one data point to one of our arms. So this may occur, say, if we're taking all of the identified liver lesions in each patient, or the largest lesion in each hepatic segment, the largest pulmonary nodule in each lung. We're doing separate gray and white matter measurements. We're looking at each colonic segment in virtual colonoscopy. Even if we have 31 renal masses in 30 patients, just one of those patients had two masses, we now have a clustered data structure. So essentially all of the standard statistical tests in this session as well as in part 2 will assume independent observations, whether we're using paired and unpaired or parametric and parametric tests. The inclusion of really any clustering will trigger the need for more sophisticated tests to model the data to account for the intra-subject correlations in deriving the p-values. And to see why this is, I'm going to kind of take this to an extreme example, but I think this may make the case. Suppose we wish to perform a study of whether liver ADC is different between men and women. And we take study design 1, where we have 20 separate male volunteers and 20 separate female volunteers. And then we take study design 2, where we take 1 male volunteer and 1 female volunteer, and we measure the liver ADC 20 separate days in each individual. So in both of those study designs, we actually will get 20 male and 20 female liver ADC measurements, but intuitively we sense that the first study will have a stronger power and that the claim that we actually have 20 measurements in the second design is overinflated. Inevitably, there's going to be tendencies for the data to be similar when derived from the same patient for that second study design, even if we, say, remeasure on a different day or change some of the measurement conditions a little bit, like, say, measure different parts of the liver. So having different lesions from the same patient here, kind of clustering our study samples, won't be as powerful as having different patients altogether. So if we apply a standard statistical test for clustered data, then it's going to treat the observations as though each from a separate patient. And that will overinflate the apparent sample size and overinflate the observed level of significance. So if we're using cluster data, we need to somehow model the data to account for the independent effect of each factor in the experiment. So these are the kind of the three items or three questions we've just gone through to ask ourselves about the data. Is it parametric or non-parametric, paired or unpaired, independent or clustered observations? And just have a list of examples, and we'll kind of walk through this for each of them. And my point isn't to really belabor this, but it's just that this is so critical that we can't really pick the right test for our data. And we're kind of be doomed to kind of use the wrong test if we're not really comfortable in addressing these issues. So say we're comparing the ADC of the patient's largest HCC pre and post embolization. So here we're just taking one lesion per patient, so it's independent. We're looking at the same lesions before and after treatment, so this is paired data. And here it's indicating it's a quantitative ADC measurement, so it's a parametric test. Suppose we're comparing the conspicuity on a 1 through 5 scale of each arterial segment in patients undergoing CTA and MRA runoff. Again, so here we have multiple arterial segments in each patient. Say we have different vessels or their thigh and their calf, so we're going to have clustered data. The subjects have undergone CTA and MRA, so these are paired. We have the two different modalities in each subject, and these are just subjective scores. This is conspicuity on a scale, basically the reader's opinion. They're not really measuring it. So this is non-parametric data. Next, we're comparing the visual conspicuity of visualized liver lesions in one group of patients undergoing CT and a different group of patients undergoing MRI. So this is clustered data. We have multiple lesions in each patient. These are whatever liver lesions they see, not just the largest lesion. This is unpaired. It's two different patient groups. We went out and we looked and we found one group of patients who had CT and another group of patients who had MRI. And these are just subjective conspicuity scores, so this will be non-parametric. Next, we're comparing radiologist interpretive confidence for separate sets of abdominal CT exams performed with and without oral contrast. So this is independent. We just have a single measurement per patient, just one overall or global assessment per CT study. It's unpaired. We found two different groups of exams with and without the oral contrast. And it's non-parametric, right? We're taking just confidence scores. It's not a direct measurement. This is just on an ordinal scale. So it's non-parametric data. We're comparing overall image quality scores between conventional and propeller MRI sequences. This is presumably in the same patients where their MR protocol included both for direct intra-individual comparison. So this is independent. We're just getting one single image quality score to each sequence. It's paired data. Each subject underwent both of those sequences for the intra-individual comparison. And like in the earlier example, this is non-parametric. It's just a subjective image quality score. And finally, we're comparing gray matter ADC between male and female patients. So this is independent. It's just a single, we're just getting a single ADC value per whether it be the gray matter or white matter. It's unpaired. We have two different patient cohorts, one for each gender. And finally, this is parametric data. It's just a quantitative ADC value. And once we've done these assessments, we can kind of see how this leads us to picking the statistical test. It really becomes straightforward. once we can answer these questions for the data, it really leads right into which test to do. When I sum it up here, at least to start out, with just a 2x2 table, if we look at whether it's parametric or non-parametric, and paired or unpaired, we just find the right box, and this will just tell us which test. So for parametric data, we will use a t-test, either a paired or unpaired t-test. And if it's non-parametric data, then we'll use either a Wilcoxon test if it's paired, and a Mann-Whitney test if it's unpaired. And all of these assume that we have independent observations. If we have clustered data, then really none of these will apply, and we'll need to do something a little more sophisticated. So if we just, I'm going to go through this a little more quickly, but if we go down our list from earlier, just based on our questions from our answers to these earlier questions about parametric, non-parametric, paired or unpaired, this will just lead us to which test to do. In this first case, when we had the paired parametric data, that would be a paired t-test. In this next case, this is clustered data, so the answer is really none of the above. And I just stress this point because I think this is a common statistical pitfall or common kind of mistake people will make. They'll apply, say, a conventional test, a conventional t-test, even when it's not correct. Here it's clustered data, so we shouldn't do that. In this next case, again, when we had multiple liver lesions per patient, that was clustered data, so it shouldn't just be one of the simple tests. In this next case here, when we had interpretive confidence, so this was non-parametric data, but it was two different patient cohorts, so this was unpaired. That would be a Mann-Whitney test. In this next case here, we had subjective image quality score, so it was non-parametric, but it was paired data. It was the MR sequences down in the same patients, so this would be the Wilcoxon test, so this would be a paired non-parametric test. And then in this final case, we had the quantitative ADC values, so it was parametric, but two different patient groups. So this would be the unpaired t-test. Again, parametric, these are the measurements, but two different patient groups. So just back to this 2x2 table, once we characterize the data, as long as we're using independent observations, if we know if it's paired or unpaired, and parametric or non-parametric, we can then identify which of these tests to use. Now, in terms of actually doing these, the paired and unpaired t-tests, these are standard functions in Excel. So we can do these readily just with that software application. The Mann-Whitney and Wilcoxon tests, these are not possible with at least the standard Excel platforms. There are packages that you can use to extend Excel statistical capabilities, some add-ins for data analysis. There are also numerous other statistical packages that can do those. And sometimes I think this is also a kind of a common pitfall that it can be kind of, be easy to just do the t-test for non-parametric data or do the t-test when it's not warranted, when we have, say, non-parametric data, just because Excel can do it so readily. But just because we can do that doesn't necessarily make it the right thing to do. And I think we have to be cautious and be on alert that when we do have non-parametric data, we do take the steps and go through the process of making sure we do the right test and not just kind of default to the t-test in Excel. So to actually go through the steps of doing this, so I'll have some examples. This is the actual format of the command in Excel for a t-test. We list the cells for the two ranges we wish to compare. Then there will be an option we could give the number of tails, whether one-tailed or two-tailed t-test. And this was the first thing from the very beginning of the talk. We generally will do two-tailed t-tests for biomedical research. This will be a 2. And then finally the type of t-test, a 1 if it's a paired t-test, and a 2 or 3 for an unpaired t-test, as we just went over. With the difference between these being if it's equal or unequal variance. There are ways to test the variance in each group. Generally, we tend to use just the equal variance form here. There actually can be quite large discrepancies in the variance before this really starts to fall apart, and the p-values we get not to be robust. It's estimated that the variances can be up to even 4 times different between the groups. and it's still okay to use this type 2 within Excel. So just some examples, and this is just some simulated data. We have the ADC values of some benign lesions and of malignant lesions. These are two different groups. And here I just kind of highlighted what our command would be for, this is an unpaired t-test. It's parametric data, right, ADC measurements. Unpaired, these are two different populations. First, we list out the cell ranges that we're comparing. A 2 because we have two different, because it's a two-tailed test as we do by default. The 2 indicates is the type in Excel because a 2 for an unpaired, and then this gives us the p-value. In this case, it was 0.477. You know, we could have two different sizes because it's an unpaired test. We're not comparing the same cohort, so they don't need to match in terms of the number of lesions. In this case, I took the exact same data set, the exact same cohort, the exact same function, and just changed it to a one-tailed. I kept everything the same, and I just changed this here from a 2 to a 1. The p-value dropped in half exactly by half. And that was the point I made from the beginning, that if you take the one-tailed for any of these tests, the p-value will be exactly half the two-tailed, right? So it went from 0.477 to 0.238. But generally for biomedical research, we will use the two-tailed t-test, and we'll be using a 2 here in this position. Here we took a different simulated data set, ADC values pre and post whatever intervention, some type of treatment. So here, this is a different study design where this is a paired data set. These are lesions that match up one by one between the two data groups. They couldn't just randomly sort one of these, that these really are matching up for each individual lesion. So here, this is parametric paired t-test. So again, we give our two ranges, and then we put the 2 because it's two-tailed, and then now a 1 for paired data, right? This is a paired test. In this case, we had a p-value of 0.001. Just to make the point that, I mean, we could put here for that same data, we could put here a 2 for an unpaired t-test, and it will run and will give us a p-value. Here the p-value is weaker, so this was the earlier slide. When it was paired, we got the 0.001. This makes more assumptions about the data and kind of lets it achieve the lower p-value. When it's not paired, this was somewhat weaker and gave us the 0.033. In this case, that would not be correct because, again, it's a paired data structure. And then just one more example. Here, this was our original data set of the benign and malignant lesions with two different cohorts. So there were different sample sizes. We see there were more lesions here in one of the groups. If we try to force this to run a paired t-test, we put here the 1 at the end with the 1 indicating the type 1 t-test is paired. It actually gives an error, it won't run because this for the paired t-test, Excel requires equal sample sizes. If the sample sizes are not equal, it can't even run the paired t-test because it needs the same number of lesions in each group to match them up one by one. And then I guess there's just one more slide. In this case, we had confidence scores. So these were just reader subjective scores on a 1 through 5 scale, just subjective confidence in the readings, just ranked. Yes, we can do this in Excel. Excel will run. It will give us a p-value. Excel won't know this is just a subjective reader opinion. But again, this is the pitfall I mentioned earlier. This is non-parametric data. It's not a measurement. The t-test isn't the correct test to do here. And just because Excel can do it isn't making this the right thing to do. In this case, we would do a Mann-Whitney test. We would do an unpaired non-parametric test. So we either need some type of extension to Excel or some other data package or some other software package that can do this. So this is just summarizing. This was that same 2x2 data, 2x2 table. If we have independent observations and we know the type of data that we're using, then from there we can deduce which of these tests to use and generate the p-value. So that wraps up this first part. In part 2 of 2 on individual comparisons will be a week from tomorrow, so Tuesday, May 10th at 6 p.m. I welcome everybody for their attention, and so I'm open now to any questions through the Twitter feed. The hashtag is radiostats, so I'm just gonna, so if anybody wants to send any questions, comments, feel free to send them along, and I'm here to, and I'm happy to do my best.